Hi, and welcome to the Focus on Eye Health Expert Series. I'm Jeff Todd, CEO of Prevent Blindness. Today, we'll be talking about health disparities through the lens of diabetes-related eye disease with Dr. Kristen Nwanyanwu, Associate Professor of Ophthalmology and Visual Science at the Yale University School of Medicine. Thank you so much for being with us.
Thanks. It's awesome to be here. It's a nice opportunity to be with Prevent Blindness and to be able to participate in the awesome work that you all do.
Thank you so much. So before we really get into this, can you tell us a little bit about yourself and what led you into a career focusing on diabetes and diabetes-related eye disease?
Sure. So I am an associate professor of ophthalmology and visual science, a vitreoretinal surgeon in the Department of Ophthalmology and Visual Science at Yale University. And I say that my path was clear pretty early. I have a history of advocacy for access to education and affirmative action when I was in high school. And then I did a lot of advocacy and activism in college with the Black community there. And then after that, I was trying to figure out in medicine where I could meet the two. And at that time, when I was in medical school at the University of Pennsylvania, it was very clear that there was a large chasm between those that had health insurance and those that did not. So, for all the young people out there, this was before the Affordable Care Act. There were millions and millions of uninsured folks, and we just couldn't get them the care that they needed. And for me, that was where I saw myself kind of in that gap. Trying to advocate for access to care. And I took a short detour. So I did my MBA at that time. And what I was trying to do is get the skills and the understanding of how healthcare systems work, because it was an enigma to me how we could have so much money and so many resources in our healthcare system, and people were still not getting what they needed. And it just didn't make sense to me. And I wanted to go. So I went to Wharton to learn about how healthcare systems work, what other areas of the healthcare system, why they could tell me what I had to do or could do as a physician, and how everybody worked together. And I thought about a career in policy at that time, but I really love patients. For me, being able to stand in that gap, that information gap between what's happening with someone and their health and what is going on is just beautiful for me. So I went and I said, I'm going to do patient care, simultaneously fell in love with the eye and said, all right, how can I kind of put all of this together? And I did what any good medical student does. I PubMeded it. And I said, look, somebody out here does something that is related to how people get eye care. And I came across the work of, at that time, Dr. Ann Coleman and Dr. Paul Lee and Dr. Eve Higginbotham and kind of the giants in the early stages of understanding equity. And I said, well, there's not a lot here, but that could be my opportunity. And maybe that's something that I could pursue. And now I call myself a health equity researcher, but then that didn't really have a name. But the biggest opportunity that I saw was in diabetes-related eye disease. And for me, that allows me the opportunity to advocate, to talk about sources of inequities that I get from my background. I have a degree in African-American history. And so, I get to talk about some of those kind of historical contexts of why we are where we are. But then the other side of things is I am an implementation science researcher. So I get to build new systems that really will advance equity. So I kind of get all of the gift of all the different worlds that I've been in. And so this point in time especially is a beautiful time to be able to contribute, and I'm just happy to be able to contribute to the field and stand on the shoulders of others that have been thinking these thoughts for a really long time and push this wave of equity as far as we can get it to go.
That's really exciting, and I have to say I'm proud to hear you mentioned Doctors Coleman, Lee, and Higginbotham, and the fact that all three of them have been leaders here at Prevent Blindness, and so we love claiming them and are glad that you're becoming part of that fold as well.
Well, good choices.
So you serve as a spokesperson for the Focus on Diabetes program with the American Diabetes Association. What role do you have there, and why do you think this initiative is so important?
Well, they asked me to really elevate the advancement of equity and to really talk about the inequities in particular Black communities. That when we were talking about it, that's where we started. But since we have been able to analyze and understand the population level data, there have been disparities in who has diabetes related eye disease, how severe the disease is, who gets screened, and it is based on societal inequities. There's not a difference there. So marginalized populations are marginalized in diabetes related eye disease as well. And so as one of the few folks that really focuses on that area, it was an honor for me to be able to come and say those things out loud, and then to be able to highlight, what are some opportunities for the future, and to be able to work with the American Diabetes Association and have that platform to say those things and to elevate that education for our providers and saying this is not the same for all of our groups, and to be able to propose some opportunity for advancement in those areas was really a no-brainer for me. And so currently, I get to work with them on their membership committee. I get to work with them on some other areas and have conversations about what equity looks like in their organization. But what I also get to do is in my research life, I get to see how we can pull some of the best practices together to address the issues. Recently, Ophthalmology, the Blue Journal, just came out with an entire thought. I don't know. It's a thought series, right? It's not just one piece. You was like, oh, a thought document or a thought paper, but it's really, ideas for the future from several different vantage points. And so what the exciting part about that is we put on paper where we are, and then we get to dream going forward as what has to happen to be able to allow our communities to access their best eye health. And we're just not there. But what's exciting is that now is the time to really think through what is available and what's next.
Yeah, you kind of alluded to the Pre-Affordable Care Act and Post-Affordable Care Act earlier, and that's certainly, the passage of that certainly didn't flip a switch on health disparities, and all of a sudden they're gone. And I'd like to dig into that a little bit. But before we do, can we talk a little bit about the condition of diabetes-related eye disease itself? So what is it about diabetes that can ultimately cause vision loss?
Yeah, the way that I like to explain it with my patients is that high blood sugar causes an inflammatory state throughout the entire body. So you can think about it like when you get a cut and it turns red, and what is happening there is that all the cells in the body are really going to fight whatever that is. And so the inflammation in the body that comes from having high blood sugar changes the vessels. And in the eye, how those vessels change is that they don't work as well as they usually do. So the natural way that the blood vessels are supposed to work is that they transport the cells inside to where they're supposed to go, to A to B. When they are impacted by the inflammation that is caused by high blood sugar, those cells actually open up a little bit. And so instead of being able to hold all those cells in, there's things that leak out. That's fluid. That's what we call exudate or swelling in the back of the eye. Also, it changes the environment in the eye where the eye thinks that it needs more oxygen. And what that does is it causes abnormal blood vessels to grow from the surface of the retina. Now, we have to talk about anatomy here. So the eye is formed around a gel when you're in the womb, and that gel just sits in the eye. But when you have abnormal blood vessels, they have kind of a scaffold to grow onto. And so those abnormal blood vessels, they grow on that scaffold. And when they get big enough, they can kind of pull against the retina. And that is where we get what's called a tractional retinal detachment, one of the devastating complications of the proliferative diabetic retinopathy stage. But what's important to note is that the inflammation is where all of this starts. And the longer that the blood glucose is high, the higher and longer that inflammatory state, or that state of just the body just experiencing all of that inflammation, is longer. And it's also in your heart. It's also in the brain. It's also what happens with fingertips and what happens in foot ulcers and other things. And it's important that we know that it's systemic. But what is also important is that the other parts of it are modifiable. So early stages of diabetes-related eye disease, we say, tell me how you're doing with your blood sugars. Tell me what the plan is, right? And how can we move forward? And what are the goals? Dr. Groot, who's in the American Diabetes Association, she has a really good model for really having an approach without shame of getting that advancement, because it's really about managing. Having diabetes is a really heavy load for a lot of folks, and it is a chronic disease, and it's something that is ever present, and the capacity to be able to manage that is something that is different for each person, and that journey is different for each person. And so figuring out what that plan is a really individualized process between that person and their primary care doctor or whoever is on their care team. And so as a part of that care team, it's really, as the eye doctor in that care team, it's really about amplifying the messages from the other people on the team to figure out how we can get you to your best place. Some of my endocrinology colleagues will tell me, there's some people that you don't want to have their blood sugars too low. And so having a specific number is really a care team conversation. But if someone is above their goal, we have to be able to support getting to that goal, but that means different things for different people. And what those conversations are about is about the autonomy and kind of elevating that autonomy, decreasing the shame of trying to manage it and the difficulties of trying to manage it, and then working together as a team to getting someone to their best health. And so as part of the team, it's really important to amplify the messages that are already going ahead of us and work together. So all that is to say is that it's really, diabetes-related eye disease is really a inflammatory state that manifests in your eye. And what we do in the very beginning stages is really working as a team to try to move forward to decrease the amount of blood glucose in the blood and to keep people in range is what they talk about now. Nowadays, it's like, how can we keep in range? And so I'm learning from being in that environment and being with those folks on how to talk about it and how to get people to their best state of health.
And really including the patient as a part of that team.
Oh my God.
As well.
In the middle, the very middle, because when we talk around, who actually has to do the work, right? Because I am an ophthalmologist. I'm looking at these pictures, I'm telling you what's going on. But if we are not engaging in a trustworthy relationship, what I say is not going to matter, and it's the patient that will really end up having to go through and to be with whatever state that they're in going forward. And, so it's really has to be centered around our patients, but oftentimes even our healthcare system is not. And so trying to figure out what the proper paradigms are or what the proper care delivery models are that we can put our patients back in the middle is what systems science right now is trying to figure out, because we haven't done that thus far.
Yeah. Well, certainly recognizing that, as you just said, it's all very individual based. Yeah. Can you talk a little bit generally about how vision loss appears within people with diabetes and what changes in their vision they may notice?
Yeah, so this is the hard part. So there are a lot of patients that don't have any vision changes, and they will have advanced disease that we see in their eye and still be 20/20, no problem. Which is why our screening systems really have to be elegant and refined to try to help find people, because we know that if we find disease early enough, we can intervene and we can keep people from going blind. But when our patients do have symptoms, they may notice a little floater. Sometimes that can be some blood in the eye, kind of it'll be like a swash of floaters. Sometimes people will have a red streak or a brown streak that they experience that could be bleeding in the eye. But diabetes actually manifests itself in lots of different ways in the eye. So our patients with diabetes have cataract sooner. They also have more dryness in the eye because of the same inflammatory changes that cause nerve damage here, also cause nerve damage in the eye. Also with eye pressure issues, sometimes those abnormal vessels show up in the drainage system of the eye as well. So sometimes you can have that, but a lot of it doesn't have any symptoms, which is why Getting screening is really important, but when you do have symptoms, sometimes people can also have central vision changes. So sometimes our patients will say, I used to be able to read this, and even if I put my reading glasses on, I can't quite see like right in the center. And sometimes that is that swelling that we talked about when the vessels don't quite hold the blood in like they should, and they start leaking out, and usually it's in the middle of the vision. So those are some of the things that you may notice. But if you have a diagnosis of diabetes, you need to just make sure that you have regular screening evaluations, because sometimes you don't even notice anything.
Yeah, yeah. Well, you kind of just alluded to this, and again, recognizing the individual nature, but how often should a person with diabetes receive an eye exam or screening, and what other ways can they prevent vision loss from occurring?
Sure. So currently, the American Academy of Ophthalmology recommends that anyone with a diagnosis of diabetes have an annual exam. The ADA is a little bit more precise about that. And they say, depending on your blood glucose control, you may be able to go to 2 years. My current state about this is that as we evolve with patient-centered screening guidelines and otherwise, we'll get more elegant about exactly who needs what. But currently, if it's been more than a year, you should definitely get back. And there's lots of different ways to do that. So we have a lot of models now about what that looks like. So seeing your eye care provider in their office is a lovely way, because that will also allow them to evaluate for cataract and dry eyes and other things that can happen that we'll miss on a telemedicine model. But telemedicine has been able to detect diabetes-related eye disease for many, many years, and is very effective at finding disease. And so that is also a wonderful way to be able to do that. So sometimes large institutions will do screening, days, or will allow you to come and get a picture taken, which is excellent for screening for for diabetes-related eye disease. But what we also want everyone to know is that there's other things beyond that. And so it's nice to be able to have a comprehensive examination in the interim.
Okay, great. Well, one of the things that really frightens me about these conditions that what we're talking about is that we know that the longer someone has diabetes, the more damaging effects it can be on the eye. And unfortunately, we also understand that people are being diagnosed with diabetes at a younger and younger age, which means they're most likely going to have an impact on their vision at a younger age. I'm assuming you're seeing this in your practice as well.
Yeah, sure. And the most devastating for me are, we still have very young people in their 30s where their disease defining diagnosis is tractional retinal detachment from diabetes, which is challenging to wrap our head around in 2022, that someone would not only not know that they have diabetes, but the first time they find out is when their eye is full of blood with blindness in the emergency department, which we should be able to prevent. We should be able to prevent this from our normal diabetes screening from our primary care colleagues, but we should also be able to do this from our screening from our eye screenings, just in general, right? Eye health is just important. And what we're learning is the path towards equity, which the CDC and others are looking to in terms of trying to increase surveillance. How can we get a better understanding of the data of where our needs are in eye care, and how can we balance the resources with those needs? But also, how can we create a community where we understand diabetes and the diagnosis in a way that is along the path for equity? We know that we're getting better at diabetes. With all of the medications available, continuous glucose monitoring, all the technology that is available, people are really doing well. And they're managing, and they keep in range, and they live a more normal life. But there's a subset of population that just doesn't have access to those things. And there's a lot of reasons for that. And our system hasn't figured out how to align those. And so I think that, going forward, there are a lot of opportunities for people to be well, and a lot of excitement in the diabetes community, because there was a long time where we didn't have nuanced treatments to be able to change people to, oh, this doesn't work, let's try this. My patients are always on a new something when I come, which is very exciting. But there's a subset of them that don't even know that they have the disease to get the treatment so they can do well. And that is where our gaps are. And that is where we need to focus our efforts in our diabetes communities. And they're doing beautifully at trying to understand that, but also in our eye community. So a beautiful analysis or evaluation of social determinants of health came out from the American Diabetes Association by Hill, Briggs, and colleagues. And they really looked deep into the literature to see what are the factors. So when we say social determinants of health, we're talking about where people live, work, play, right? How you advance yourself towards your best health. And there are a lot of things there that aren't biology that really impact how well someone can manage their diabetes. And this includes, built environment, where someone lives. This includes food security, right? Food insecurity is associated with increased diabetes, and people may be confused by that, meaning if you don't have proper resources to get food, your diabetes is often worse. But you can think about the opportunities to be able to take good care of yourself when you're just trying to figure out how to eat. And these are very challenging problems, but very American problems. Mm-hmm. And so it's hard to reconcile how we can have these very, very wonderful advances in technology and pharmaceutical companies with these patents and doing all these wonderful things to advance people to the point where they just have a little tap and they take great care of themselves. But then we have a subset of our population that doesn't have enough to eat, particularly in times of inflation and times of unemployment. And how can we support them? And also, we can't get off of here and talk about the cost of insulin, right? And so like life-saving treatments that somehow are unattainable to a subset of population. Our path to equity has to include all of those pieces. And it's challenging because we weren't really built to do that, right? We're built to advance science, we're built to create revenue, but we haven't been built to advance people's health. And so when we think about what are the models that are appropriate to be able to do that, we just have to, like you said, go back to patients. And a lot of times patients are in community. And we learned from the COVID-19 pandemic when we had to go to community and say, we're not getting this right. Could you please help us figure out what are the best ways to advance health? And you're seeing a lot of organizations that are doing that and humbling themselves to the expertise of community and how to get the word out and try to figure out how to do that. And I really think that Prevent Blindness is one of those communities, right? Just like the American Diabetes Association hosts a lot of those communities to be able to elevate what are the patients saying, how can we do better, and then what are the paths going forward that will make that path easier.
Oh,
sorry, that was a lot.
I appreciate you saying that, and I agree. While we're certainly in some challenging times societally, and as it relates to health, I have to say I feel we're also kind of in an innovative space that's kind of exciting about where it could take us. So, and
the juxtaposition is really important to feel it. There's one of my favorite books is The Book of Joy. It's by the Dalai Lama and Dr. Desmond Tutu, one of my favorites. And the reason that I love it is because it came to me from one of my patients. She recommended it to me in a part of the pandemic where I was really grateful to have the privileges that I have. I was really grateful to be alive, but there was a lot of devastation. And then there was a lot of tragedy, and there was a lot of death, and there was a lot of loss. And, what does it look like to hold those two things together? And it really allowed me to do that. So, now when I move through the world in this place of science, I can say, here's where we need to do better. And here's our technology that we're so proud of. We're so proud of this innovation because it's very American, right? Like, how can we even make these things, right? I was like reading about flying cars with my 6-year-old, like real flying cars. It's crazy. And so how can we harness that, right? Can we figure out there's a middle ground somewhere where we can loop around these excellent innovations to be able to elevate the health of communities that have been excluded? And, I think what's a beautiful thing about that conversation as well is that institutions like Yale have to prove that they can support community, right? There's a long history of, institutions just not being trustworthy for communities. And so being honest about that history, but also honest about the next steps and proving ourselves worthy. My mentor was really talking about this and highlighting this. She'll talk about it. We're doing a equity in eye care webinar through Arvo, and she's going to talk about this, Marcella Nunez-Smith. And I think it's really important to be able to do that, to say, we haven't always gotten this right, and let's try again, right? And so can we humble ourselves to the wisdom of community organizations, to the wisdom of matriarchs, faith-based institutions, and other places that have been ushering communities for years, and align ourselves with the goals that make sense, and then push our health, collective health, together.
Well, you've been talking a lot about other people's great work, so let's talk about some of yours for a second.
Oh, yeah.
You're the principal investigator for the SEEN Lab, the Site
Yeah.
Saving Engagement and Evaluation in New Haven. Can you share a little bit about what that is and what you hope, how it came about and what you hope comes from it?
Sure. So I am on a career development award funded by the National Eye Institute that I'm very grateful for, that allowed me to have training in quantitative and qualitative methods in community-based participatory research through Yale and through the Yale Faculty Scholars Program that they have here and the NCSP that we have. And through our work, we have done a few things. So we did big data analysis of the NHANES data and found that 70% of people that had diabetes in that cohort, that's the famous 2005 to 2008 cohort. We're going to nerd out for a little bit. Sorry, folks. In NHANES, where they took fundus photography of all the patients. And so then they asked them, do you have diabetic retinopathy is the question, or do you have, diabetes in your eye, I think it was. And then they looked and took pictures. And so it's one of our only opportunities to actually kind of pair what people know or what they are aware of and what we actually see. And so we determined from our analysis that 70% of folks were not aware that they even had it, which gives us an opportunity to develop that awareness. And, there was not a racial or ethnic predilection for this. And in fact, our communities of color were more aware than not, which is a nice opportunity as well. And so what we did then is we looked at our New Haven population and we said, okay, here is our population and who's at highest risk for diabetic retinopathy. See, we looked at the cohort in Yale New Haven Health System to see who developed proliferative diabetic retinopathy and what were the characteristics that were associated with them in particular. Now, our rates were pretty high, unfortunately. And so what we did was we developed a pilot with our community partners. Our community partners is a beautiful organization here called Project Access New Haven, and they do social determinants of health for their clients, and they also do care coordination. Now, usually they do them in silos. Usually someone either gets kind of care coordination if they need like a cancer surgery, or social determinants if they are kind of paired from a low resource setting. But for our participants, they actually do both. So we get them into the clinic, we do a full evaluation with them, and then our Project Access community partner discusses with them. They do a whole hour intake about their social determinants of health, what's getting in the way of care, what are the facilitators of getting good care, like what are the things that they have going for them that will probably help, what are their motivators and all of this. And then they follow them through a whole year. And so what we get there is data. So what we don't understand is what it really takes to really usher someone to their best eye health. We know that we're missing. And we know that there's something beyond biology that is happening. But what are those things? And social determinants of health give us an opportunity to ask, what are the things that our patients need? And then how to get them to them and what does it cost? And so our community partner actually has a very extensive system for metrics and for cost and labor and for understanding exactly what the effort is that it takes to usher someone through the healthcare system. So when I think about this program, it's really about understanding how to best allocate resources. So I don't know if you tried to navigate the healthcare system recently, but it's not easy. And I'm a whole doctor, right? But it is not easy to try to figure out where you're supposed to be, what you're supposed to do, how to click, how to, all of the things, let alone with the constraints of that some of our community members have. And so what does it look like when I spend a little bit of extra resources on people that I'm worried about, whether it's because they are not connected to the system of primary care, they have high A1Cs, they have comorbidities, which may be a foot ulcer, kidney problems, complicated high blood pressure. So what does it look like to support them in a way that may require a few extra resources? But if we can keep this subset of our population with their vision, a lot of times that is worth it, because I would like to stop telling truck drivers that they no longer can drive. Yeah. I would like to stop telling our breadwinners in their 30s that they can no longer support their families. And this is what happens when, in our current model, in our current system, in urban environments with high levels of poverty in New Haven. And so I am piloting this to try to figure out what are the levers that we have to work alongside some of the other beautiful things that we know work well. And, if I can just add, there's some beautiful systems that are being developed. Dr. Newman Casey, who I believe, in Michigan, has developed a beautiful model at a federally qualified health center for building low resource eye disease detection center. And so it's not just, how can we screen everyone, but it's really like, how can we create a system that allows us to deliver appropriate care in people that don't really have care, don't have access. And what they're finding is that they have identified increased prevalence of disease in these communities, and they have identified also a pathway towards keeping those communities adherent. She has community advisory boards and things like that. And so we'll talk about this in our webinar next month, but we really need to talk together about what are the models. How can we do this? Because the resources for eye care are actually kind of intense. And, to deliver good care, what are the necessary tenets of doing that? Another great model is Yale, who's in Wisconsin, who has developed a teleophthalmology toolkit, which I refer to all the time. And it tells you kind of what camera to do, how much you need, like where it should go, and and all of the basic things that you need to try to develop that. And so with all of these researchers and their pieces in these settings, and if we come together, we can figure out how to build those models. And I think that's where we are. Dr. Lee is kind of the champion of systems. And he's told me the other day, he's like, we have to figure out what are the best models. And then also when we're building models, communities really have to be right in there. Because if you build something and nobody wants to come, whatever reason they don't want to come and nobody wants to come, it just costs a lot of money. It doesn't help anybody. Yeah. And so trying to figure out quickly how, because we got to sprint. This is a big problem. It's old, but it's bad. And so we have to figure out quickly how we can make these systems, how to make them work, and how to scale the ones that work and get rid of anything that doesn't.
Absolutely. Yeah. But you touched on a lot of different drivers to health disparities, but real quick, I'd like to just talk about one of the kind of basic ones. Back to the Affordable Care Act, there was this belief that maybe that would solve things. Of course, we know it didn't solve everything. Yeah. And affordability still is an issue for way too many people. So if someone's diagnosed but doesn't have the financial means to access care, are there resources or services you recommend, or what do you tell those people?
Yeah, fortunately, at Yale, we have a system for that. But everybody doesn't have an academic center that has subsidies for those populations that are close to them. And currently, we're not doing that well in creating a network to be able to do that. We could do a lot better. So how people usually manage it is certain areas have big county systems that have some resources for folks, but a lot of times those systems are overwhelmed. Though if you look at the work of of the LA County team. It's Dr. Daskovich and her team, where they developed an artificial intelligence algorithm to actually identify folks that are at highest risk because people were going blind in the queue. And it's one of those things where it's like parallel innovation, but also in tragedy. So I think what we need to do is figure out how to knit that together. So the Academy has a program that's an old program called I Care America. That's an old program where, you know, ophthalmologists will donate their care, but it's a small program, and the number of folks that have eye disease that needs care can be mitigated by that, but we can't solve it that way, and we don't have a proper network for that. It's an interesting dilemma of subspecialty care in low resource communities, and you know, there's a body of literature that said, like, if we just get everyone primary care, we can figure it all out. But as we know with eye care, it's just not enough. And the way that it's designed, we haven't figured out how to do that. Fortunately, in New Haven at our Cornell Scott, they have in their federally qualified health center, Dr. Susie Forrester created an eye center there. So her legacy is very strong, and that eye center still exists. I remember I visited here and I couldn't believe that when they diagnosed with somebody with diabetes, they would just say, all right, now you just walk over. And they would check at the eye clinic, do you have an appointment? And they would say yes, and they would bring them in and they would look right then, which is how it's supposed to work. But we know 80% of federally qualified health centers, they don't have eye care.
No.
And so what does it look like to build that? So I'm looking for, this is one of the things that's amplified in this most recent thought paper that talks about access to care in the Blue Journal in Ophthalmology. And what I'm looking for the Academy to do after that is to make some solutions. So what does it look like for the Academy to really stand in that gap and work towards creating opportunities for people to have their best vision? I mean, can you imagine what kind of impact would that be for this big organization that has strong lobbying to be able to really do that with the benefit of, you know, organizations like yourself and others that have really been advocating with this for years? So like you said, it's a beautiful time to see and work towards what the next step is.
Yeah. Well, just as a quick plug, you just mentioned that too many FQHCs don't have vision care, and I think 80% may be a little low. But Prevent Blindness has recently partnered with the Association for I'm going to get this wrong, the clinically underserved, I think, and the National Association of Community Health Centers to do a series of webinars about integrating vision into community health centers. And so I certainly encourage folks to visit that. And we also have a resource page on our site for financial assistance resources that includes I Care America and others. But that's just a drop in the bucket.
But isn't there's a grant, right? I think there's a grant too for trying to like build, right? There's a grant associated with that.
For folks who want to take that on. So
yeah,
I'm excited to see there's at least interest in that area. We just need to increase funding for that.
Yep.
So, you know, as we wrap up, Dr. Nwanyanwu, do you have any final thoughts for the audience today about diabetes and vision or disparities? We've covered a lot, I know.
I think one thing that we didn't talk about that is really important is the data. And we need appropriate data to be able to make plans for the future. So right now, there is a group of folks that is trying to improve our surveillance of vision health in the United States domestically. But we really need to elevate those data and to use all the data we have to try to understand how we need to go forward. And there are some databases that are, you know, proprietary that have some of these data, but we need to figure out how to put it all together. And then also we need to be able to work together to determine what questions to ask, because there need to be an acceptable and universal set of metrics for how we figure out how well we're doing. And we all need to have to demonstrate that going forward. So how are we doing on equity? And it can't be in every 10 years we find out that we're doing bad again, right? Like we have to figure out, and data is something that we can do on multiple levels. And then also that we can share in community. I know that there is a new, I guess it's not that new, a fairly new innovation about patient-related outcomes. And I think this is a beautiful step in understanding how our patients see, pun intended, I guess, how they see where we're going, right? And so asking our patients, what are the things that matter to them? And then holding ourselves accountable to what we ask for is really important. We need to know the proportions of folks below the poverty line that get the care that they need. We need to know about our marginalized folks and who is getting the care and who is not. And then we need to know what our aspirations are and what are the evidence-based things that we can do to try to get there. And if there are none, we need to have funding to be able to ask those questions. And I know that the National Eye Institute is very interested in advancing equity. And so there's some beautiful RFAs about, how we do this. And I know that the artificial intelligence community is really interested in this, because if they get this wrong, we could have a really big problem. But if they can analyze this and get this right, then we may be able to, like you said, jump some of the issues and really push ahead these equity advances. And so I think really when we're talking about understanding the data and getting more data, the more the better, to be able to understand where we are, where we're going, and how we can center where we're going on patients and patient experiences, I think the better we'll be. Because right now our data doesn't really tell us how people are seeing or how people are moving through the world or how people are experiencing working and doing the things that they need to do to support their families. And so if we can figure out what are the data metrics, how can we incorporate those on a large scale, so like we really understand how people are experiencing things instead of one or two questions here or there, and I think that we can really go forward. So that's the only thing I think we really have to focus on that I love talking about is data.
I think data is really exciting, and as you know, our colleagues at the CDC and at NORC at the University of Chicago are doing some great work around the vision and eye health surveillance system.
Yep.
And we're working with them. We have some information on our website about their work, but unfortunately, it's so woefully underfunded, and so we need to continue to hammer that home on Capitol Hill that investing in data as well as programs for vision and eye health is so important as a country.
And there's a precedent for that too. I was going to say, I just want to say in the Health Equity COVID-19 Task Force, there was an executive order that was done about data, and they really put forward in their final thoughts that we need to really refine how we are getting our data, what data we need, and what is going forward. So in terms of equity, I love that precedent, because now we can say, hey, look, it's really important. It's here. You guys have done it before. So let's just kind of continue that movement where we haven't had that in the past.
Yeah, absolutely. Now we just need to get our policymakers to support that and move it forward. Well, Prevent Blindness is a patient advocacy organization, but we also know it's so important for individuals and patients to be able to advocate for their own health. Could you talk a little bit about ways that people can do that?
So I think the best thing to do when you're in a health setting and advocate for yourself is to make sure you understand what is going on. And, it's a hard dynamic, because especially doctors, sometimes we get to talking and all the jargon comes out and it sounds, like muck, right? So, advocating for yourself in those settings means, let me make sure that I understand. Or, what do I have to do because of this? Or, restating what your doctor is saying, or asking for some materials at the end and not being afraid of that. And then also, if you have a provider that makes you feel ashamed or like you shouldn't be asking, don't be afraid to try to find another one. There's a lot of loyalty to doctors and other things because they always have been, but I always advocate, and even to patients that are seeing me, that if there seems to be a disconnect, that's why there's more than one doctor. Now, some of our rural settings, there's not. and that is just available what is available. But even in the advent of telehealth and being able to connect in different ways, we're now seeing other opportunities to get that information. Also, using trusted information. So the Academy of Ophthalmology, Prevent Blindness have a lot of resources that give the basics in plain language about what is happening with eyes. And those are really trusted resources. I want to just say a lot of times you can go and play Dr. Google and it gets really scary really quickly. So you want to make sure that you have a trusted resource that you're reading on your own and understanding. But, don't be afraid to say, okay, let me just make sure that I can tell you what you're saying is happening so you can restate what is going on. I think also inequities are really important to see. And then if you see that, or if you feel that, to say something. Healthcare systems have an obligation, if they get federal funding, to provide equitable care. And so they do care if you're experiencing something that you think is different, or you think that is that is inequitable based on your race, your religion, however kind of discrimination that you are feeling. And that is very important to be able to report. I think another thing for advocacy is that we think of health as unrelated, but we're saying today how close policy is related. So if you've had an experience where you need to access your health, connecting with your legislators is really important. Writing to your state senator, writing to your senators, writing to your representatives about what's happening in healthcare is really valuable. They have to listen to you. You put them there. And because right now we're at the point where the election's coming up, I don't remember when this is coming out, but you got to vote. And so you have to make sure that the people that you're putting in office will advocate on your behalf. And you can read about their platforms. They have to tell you. And so if it seems like what they're advocating for healthcare doesn't align with your personal values, then you got to pick the other person.
Thank you so much, Dr. Nwanyanwu. I really enjoy these conversations with you and just look forward to having more in the future.